So I'm starting your dental implants classes from today. As a theory point of view, so you will have 1 or 2 questions from dental implants. Usually 1 or 2 questions. If you see past questions, you'll have questions from dental implants even in your viva also. So first is definition. So define dental implant. Usually in your exam, so define dental implant, write down, and sometimes your peri-implant mucositis and peri-implantitis. Okay, so definition, you must, all of you should know the definition of dental implant. So what is dental implant? It is a permucosal device. So permucosal means it is usually placed on the gingiva into the alveolar bone. So usually alveolar bone which is covered by your mucosa, that is gingiva. So it is a permucosal device that is biocompatible. So it should be biocompatible and biofunctional. So after placing implant, it should function as well and is placed on or within the bone. So if you place implant on the bone, that is called subperiosteal implant. If you place within the bone, that is called endosteal implant, which will come again. So basically it is placed on or within the bone, associated with oral cavity to provide support. So it should provide support for fixed and removal. So with the help of implant, you can either place fixed prosthesis or sometimes removable prosthesis also. So this is from Journal of Oral Implantology. So what is dental implant? Dental implant is a permucosal device that is biocompatible and biofunctional, which is placed on or within the bone with oral cavity to provide support for fixed and removable prosthesis. So this definition, so if you write proper definition, you will get 1 out of 10. Okay, so you should know dental definition of dental implant. You all should know. So next is implantation. Something called as immediate implant or immediate implantation, early implantation, and late implantation. So what is the immediate implantation? What is early implantation? What is late implantation? So this is early implantation. They go after completing your BDS, go for private practice. Nowadays, people come for implants. As well as available, it was difficult. So when we started an implant, it was difficult to get. Nowadays, patients will have an implant on their. Relative contraindication, current infection. So you should, or absolute implant on, you have to take. Last for today is advantages and disadvantages of implant supported prosthesis. So what are the advantages and disadvantages? So advantages are more. So if you place implant after extraction of tooth, the maintenance of bone and vertical dimension of face. So you can maintain the bone buccally as well as vertically. And you should, all of you should know that after you extract tooth, there will be resorption of bone. If you replace the tooth with implant, that resorption can be prevented. So that is the main advantage of your dental implants. You can prevent resorption of alveolar bone if you place implant properly. And after placing implant in proper place, teeth position in proper position for proper appearance. So appearance of look of patient, like especially on the aesthetic area, upper anteriors. So you can maintain that improved psychological health of the patient, increased success rates convinced to your conventional prosthesis. So the success rate of implant is more than your bridge or removable prosthesis. And nowadays, patients do not go for bridge, do not go for crown cutting of adjacent teeth. And of course, if you go for crown cutting of adjacent teeth, then after a few years, that tooth go for endodontic treatment. So that's why no need to go for endodontic treatment, crown cutting of adjacent teeth if you go for dental implants. Another advantage, establishment of proper bite. Because in bridge or removal prosthesis, in bridge you are dividing the force from the adjacent teeth. In removal prosthesis, you are taking load from the edentulous ridge bone. So the chances of resorption of that bone is more. Increased bite force. Yeah, bite force can be increased. I've already told you, because we are taking directly from the alveolar bone. So that is why your chewing performance can be increased, improved. You can increase stability and retention of removable dentures. So if you are planning for removable dentures, there is something called as dental implant supported overdentures. So retention is more with that. There will be improved speech with dental implant. You can reduce the flanges compared to your removable dentures, and in overall there will be improved health of the patient. So there are a lot of advantages of dental implants. So that's why dental implants are increasing nowadays. Because 10 years back, patients, it was very difficult to convince patient for implant. One, because of cost, and another one is because of limited knowledge of the patient. But nowadays, patient, they come to you for replacement of missing teeth with dental implants. However, there are few disadvantages. One is cost. Cost is little higher than your and bridge. It requires operators' skill. So you need training for dental implant placement. And one of the important is maintenance of oral hygiene. So patient compliance is very important in case of dental implants. Because if you do not maintain oral hygiene after placing implant, chances of failure, chances of peri-implant mucositis and peri-implantitis is more. So this is the, so if you see disadvantages and if you see advantages, there are a lot of advantages of dental implants with limited disadvantages. I will show you implant cases. Okay. So suppose patient comes to you with fractured tooth and you cannot save that tooth endodontically. No root canal treatment with post. Then what do you do? So this is a case with fractured 1-1. So we go for CBCT. Okay, you can see the fracture root. So we plan on CBCT with the software. We measure the distance, whether we can go for immediate implant or not. This is the case of immediate implant. So you can see, so this is the lateral side of the tooth. So we can go beyond the root apex. So we need 3 mm length for immediate implant, at least 3 mm length apically. And we have to place implant on the parietal side. And this is the occlusal view. So usually nowadays I do a flapless surgery. So previously, few years back, I used to reflect the flap, but nowadays no reflection of flap. Just extract the tooth with the help of instrument called as periodome. So periodome is instrument that is used to remove the tooth automatically. So we have to remove the tooth automatically without causing trauma to the alveolar bone. So after that, we start drilling. We prepare for the implant site. So usually we go palatally because buccal plate is thin. So you cannot go buccally. If you go buccally, you can perforate buccal wall. Then this is the implant. This is a novel biocare implant, novel active implant. So this is the design of implant, which is usually for immediate loading and immediate implantation and immediate loading. So nowadays you can choose. There are a lot of brands of implant in market. You can choose as per your need. So this is for immediate implantation. If you see, these are the threads of implant. So this is threaded implant. So threads and these are tapered shaped implant. So this thread will go into the alveolar bone and engage the alveolar bony plate. And this is the placement. So usually we place the implant around the cingulum area, slightly palatally, so that your implant screw will come palatally, which will help in your restoration. So this is the implant. So we place the implant immediately after extraction. This is called immediate implantation. So what are the advantages? So same day extraction, same day implant placement. And if you see, I place this implant slightly apically. So usually you can place 1 mm apical to the alveolar crest. So after that we check whether the implant is stable or not. So we have the instrument, we have something called as torque range. Torque range, we measure the primary stability with that. So if the torque is more than 35 Newton centimeter, then we can immediately give ground. So we place bone graft on the buccal side between implant and buccal plate, and then we make incision and prepare the immediate crown. So this is the immediate crown given on the same day. So you can see on the same day you can send your patient with the implant and crown. And this is the IUPA. Now this is up to this is implant, this is abutment, this is temporary abutment, and this is the crown. This is acrylic crown. That's why it is slightly radio opacity. And this is follow up after 3 months. Now you can see perfect healing. There is no loss of interdental papilla after 3 months. No loss of interdental, perfect healing of gingiva. Then after 1 year, so patient came after 1 year for the replacement of temporary crown. Okay, so but you can see slight inflammation. This inflammation. So patient was pregnant, and no slight scaling was done for that patient, and radiograph was not taken, and the temporary crown was removed. You can see the buccal. This is the buccal plate, almost like your adjacent teeth. So after removal of the crown, so perfect healing of your gingiva, and this is after your permanent crown. So this is zirconium crown. So zirconium crown was given to the patient, okay, and after scaling you can see slight reduction in the inflammation. And X-ray was not taken during pregnancy. We do not go for X-ray, any kind of X-ray. So X-ray was not taken for that patient. So this is after the delivery of your permanent crown, and you can see interdental gingiva. There is no loss of interdental gingiva. So this is the advantage of immediate implantation with immediate loading. So immediate loading means placement of crown on the same day after placing implant. So nowadays on anterior tooth or anterior teeth, I go for immediate implantation with immediate loading. So before starting treatment, immediately after surgery, after 1 year, and after giving your permanent crown. So anteriorly, nowadays I've told you I do a lot of cases like these cases, periodontally compromised patient. See the smile of patient, and extraction without raising flap, implant placement, and this is called, after placing implant, this is called as healing abutment. So healing abutment, implant, IUPA, and this is on the same day or second day. So nowadays I send the impression to lab for proper finishing. So on the second day, so within 72 hours you can give crown. So on the second day, this was the crown given. So after 1 month, and even lower also, lower 4 teeth were extracted and 2 implants were placed. And this is implant supported temporary prosthesis. So these are acrylic temporary. So this is 2 months follow-up. So another case, extraction, root portion, placement of implant, placing implant, bone graft between implant and the buccal plate. So impression, healing abutment. This is the fabrication of temporary prosthesis in temporary abutment in lab, and this is the temporary prosthesis. So you can see there is no bleeding. Patient can brush after 1 day of placing implant with crown. So this is the advantage. So nowadays, this is called minimally invasive implant dentistry. So minimally invasive. We're not reflecting flap. On the first day or second day, patient is getting crown without any bleeding, without any discomfort. Now moving into our continuation of dental implant class. So yesterday we have discussed about definition, implantation, types of implantation, difference between teeth and implant, indications, contraindications, advantages and disadvantages. So now after that, so we'll continue with implant soft tissue interface. Soft tissue means gingiva. Okay. So in implant we don't call gingiva. So the soft tissue that surrounds dental implant is called as peri-implant mucosa. So that means if implant is placed on one, then that gingiva, that mucosa around the implant is called as peri-implant mucosa. You should be very clear. And when do you get the feature of peri-implant mucosa? So during the process of wound healing. So after you place implant, so there will be healing. Okay, and you close the flap. So closure of mucoperiosteal flap following implant installation in one stage. So there is something called as one stage implant and two stage implant. implant procedure. So we're talking about implant soft tissue interface. So implant, you have implant and soft tissue, implant and hard tissue. So implant and soft tissue means gingiva. But the soft tissue, we don't call gingiva in case of dental implant. The soft tissue that surrounds dental implant is termed as peri-implant mucosa. So now the gingiva is replaced by the term peri-implant mucosa. And when the features of peri-implant mucosa is established, so you have something called as one-stage procedure and two-stage procedure. So one stage, very simple, one-stage procedure means we are placing implant and we are placing healing cap also. So in that condition, we don't go for second stage surgery. So that means in one stage, your implant and peri-implant mucosa will be formed. Whereas in case of two-stage procedure, we place implant, we give suture, and after a few months, we again open the peri-implant mucosa and place healing cap, so that peri-implant mucosa is established. And the healing of mucosa results in establishment of soft tissue attachment to the implant. And this attachment serves as a seal that prevents products from oral cavity reaching the bone tissue. It's like your gingiva. So gingiva also provides seal so that oral microorganisms or anything from oral cavity do not go into the alveolar bone. So the peri-implant mucosa and gingiva are same in case of implant and natural teeth. It also ensures osseointegration and the rigid fixation of implant. Now you should know that what are the differences and similarity between peri-implant mucosa and gingiva. So we'll discuss about that. So if you see the color of gingiva and peri-implant mucosa, it's pink in color. So actually you cannot differentiate by looking if implant is placed properly, then you cannot differentiate between the natural teeth, there is gingiva and peri-implant mucosa. So color of both are pink with firm consistency. Even in that picture also, it's difficult to appreciate whether it's implant mucosa or gingiva. So color both pink in color and firm in consistency. So radiographically, your alveolar crest, alveolar bone crest, is located about 1 mm apical to the line joining cement to enamel junction. Your alveolar crest. Whereas in case of implant, so these are implants, so bone crest is close to the junction between abutment and fixer. So properly placed implant, your bone will be in between. This is implant and this is abutment. So in case of implant, your alveolar bone crest is usually located between abutment and the implant junction. Oral epithelium. So oral epithelium is in healthy teeth. It's a all of you know, it's a well keratinized, continuous with the junctional epithelium that faces enamel and that ends at the supraalveolar connective tissue is about 1 mm high, that is connective tissue. Width is 1 mm. Periodontal ligament is present around the teeth, which is about 0.2 to 0.3 mm in width, and principal fibers extends from root cementum in a fan shape. So this is a normal, we're talking about normal teeth. Whereas in case of implant, in case of peri-implant mucosa, outer surface is keratinized oral epithelium. So it's like your natural teeth, like gingiva. There's thin barrier epithelium, which is similar to junctional epithelium at the teeth. So there is junctional epithelium. But I told you yesterday that there is no connective tissue. So there is outer epithelium, there is junctional epithelium, but there is no connective tissue. The connective tissue in the compartment above the bone appear to be in direct contact with the surface of the implant. That means there is no connective tissue. And the collagen fibers in peri-implant mucosa runs parallel to the surface of the abutment. Because there is no cementum, there is no attachment of fibers, there is no periodontal ligament. So that's why the fibers of the junctional epithelium will run parallel to the surface of abutment. So you should remember these things. So implant epithelium junction, same as junctional epithelium around the tooth. And epithelial cells attaches to the implant surface by hemidesmosome and basal lamina, like in natural teeth. Just write down first and second. No need to write third and fourth. First and second. So all of you know vascular supply of gingiva. There are three sources of blood supply. One is from crest of the bone, large supraperiosteal blood vessels, and blood vessels from the periodontal ligament. Now this is the difference between your teeth and implant. So there is no periodontal ligament. That means so blood supply from periodontal ligament will be absent in case of dental implant. Whereas there will be blood supply from the crest of bone and large supraperiosteal blood vessels. So in case of implant, vascular system of peri-implant mucosa, so large supraperiosteal blood vessels. And these will form capillaries beneath the oral epithelium. So usually you have to remember that in case of implant, there is no periodontal ligament. So the blood supply from periodontal ligament will be absent. So usually large supraperiosteal blood vessels will supply to the implant. Probing gingiva and peri-implant mucosa. Yesterday I told you that gingival sulcus depth around the implant is more. So if you see this picture, in case of natural tooth, so there are principal fibers, secondary fibers, so they are running from the teeth to the gingiva. Okay, so if you probe the gingival sulcus, then these fibers will obstruct. So that's why your gingival sulcus depth is 2 to 3 mm clinically. Whereas in case of implant, so there is no principal and secondary fibers. They are only parallel fibers. So that means these fibers, so these will allow your probe to go apically, more apically. So that means gingival sulcus depth will be more in case of dental implants. So after soft tissue interface, we have bone implant interface. And in this we have different theories of integration. So theories of integration, we have fibro-osseous integration, and osseointegration. So fibro-osseous integration was given by Linko 1970, James 1975, and Weiss in 1986. Whereas osseointegration was given by P.I. Brenemark in 1985. So yesterday I told you 1952 he discovered implant. 1965 replaced first implant. The theory of osseointegration was given by him on 1985. So after a long study on the titanium, he gave the theory of osseointegration. So what is fibro-osseous integration? So according to Weiss, so there is fibro-osseous ligament present between implant and bone. And this ligament was considered as a periodontal ligament. But there is no periodontal ligament, so that's why this theory is not accepted. And it also defends the presence of fibers in the whole bone implant interface. Osseointegration, Professor Bernemark, who is I told you, orthopedic surgeon, University of Gothenburg, Sweden. This is not required. Now, Bernemark's theory of integration. So Bernemark proposed that implants integrate with bone such that bone is laid very close to the implant material without an intervening connective tissue. So I'm telling you, bone will directly attach with the implant surface. There should not be any kind of fibers in between these two. It's like ankylosis. And according to him, implants should not be loaded. According to him, I have shown you my cases where immediate loading was done on the same day or next day, immediate loading. But according to him, implants should not be loaded. We should not keep crown after placing implant, according to him, and must be left out of function during the healing period for osseointegration to occur. So initially, Breneman thought that we should not give load to the implant, no crown, because it may prevent the osseointegration. But nowadays, after 1985, there are a lot of inventions in implant. There are a lot of changes in implant design, implant surface characteristic. That's how we are loading nowadays implant. We are giving crown, which is against his theory. And you should know one definition of osseointegration. So there are a lot of definitions of osseointegration. So I'll tell you which one to write. Okay, write first and second. This was in Noleka. And write this one, 1985. Brenemark, Zarb, and Albertson. So osseointegration ko, you should know one definition. Just write down osseointegration. Define osseointegration. Exam I think पहिला सोधेको पनि छ, सोध्न पनि सक्छ. So osseointegration is the direct structural and functional connection between ordered living bone and load-carrying endosseous implants at the light microscopic level. So write down this first definition. Osseointegration is the direct structural and functional connection between ordered living bone and load-carrying endosseous implants at the light microscopic level. You can write one more definition, 1991, Zarb and Albertson, a process whereby clinically asymptomatic rigid fixation of alloplastic material is achieved and maintained in bone during functional loading. So, definition, write down. So, osseointegration is a process whereby clinically asymptomatic rigid fixation of alloplastic material is achieved and maintained in bone during functional loading. During chewing, during functional loading, it should be maintained in bone. It should not move, it should not fail after osseointegration. Next is process of osseointegration. That means how osseointegration takes place. That means in another way, healing after implant. So after you place implant, how the healing of implant takes place. So this is called process of osseointegration, which is import exam सोध्न पनि सक्छ अहिलेसम्म सोधेको छैन. So process of osseointegration short notes मा पनि सोध्न सक्छ. So within 24 hours after placing implant, so within 24 hours, the initial mechanical stability is through the press fit. So after you place implant, there will be some stability is present. So that is initial mechanical stability through press fit. There is minute lateral displacement of bone tissue and tight contact with the bone. And there will be formation of blood clot after placing implant due to severing of blood vessels. Now this is a picture. So this is black. Black is implant, and these are bone tissues. So after you place implant, because of primary stability, you will get initial mechanical stability. There will be lateral displacement of bone tissue while placing implant, so that you can get tight contact, and the blood vessels. So there will be blood vessels which will be severed due to the formation of blood clot. Then after 3 days, so after 3 days, blood clot will be substituted with granulation tissue, like your other healing process, which are rich in neutrophils and macrophages. So all of you know, the first cell that comes in healing is neutrophil. So neutrophil will start coming into that area. So after neutrophil and macrophages, leukocytes will start to decontaminate the wound. Vascular structures now start proliferating into the granulation tissue from the marrow spaces of peripheral vital bone. After 1 week, so reparative macrophages and undifferentiated mesenchymal cells will produce and release growth factors, and this will stimulate fibroplasias through which an undifferentiated provisional connective tissue forms in apical trabecular region of the implant site. So macrophages, undifferentiated mesenchymal cells, so they will start releasing growth factors. And osteoclast occurs. Now osteoclast, all of you know osteoclast are after 2 weeks, woven bone. So woven bone with primary osteons has formed at the base of surgical site, and peaks of the threads of screw type implant, discrete areas of bone resorption can be seen. Until 2 weeks time, the implant stability at this interval is still maintained through press fit. That means your primary stability. So woven bone are the first bone which comes during the formation of any kind of bone healing, and there after 4 weeks. So bone line most of the part of the implant surface. So all around the implant surface is woven bone. Now this is the first phase of true osseointegration. We want woven bone, so that after a few days, after a few weeks, this immature bone will be replaced by mature bone. So this phase of molding is followed by phase of remodeling. In alveolar bone, this modeling and remodeling is a continuous process. So during which the woven bone is substituted with the lamellar bone with a good potential to take up and distribute load. So I told you immature bone will be replaced replaced by mature bone. So woven bone is substituted by lamellar bone. So this is after at 4 weeks, 8 weeks. So remodeling will continue. So all the woven bone will be substituted by lamellar bone. Titanium surface lined by thin rim of lamellar bone, lateral to which marrow-rich in adipocytes will be observed. And then Haversian canal can be observed in the lamellar bone within the zone of press fit and in the adjacent bone tissue. That means your process of osseointegration will go on continue. Your woven bone will be replaced by lamellar bone. Then you can also see Haversian canal around the lamellar bone. So after 4 months, healing continues. All portion of maxilla form. So in short, after placing implant, so you drill the bone. Okay, while drilling the bone, you will severing the blood vessels, small blood vessels. You are actually giving trauma to the bone. And after placing implant, so there will be blood clot around the implant surface. There will be formation of granulation tissue and granulation tissue. So there will be release of growth factors. Then there will be neutrophils, macrophages will come, and the bone around the implant, it has to be replaced by new bone. How? So there will be resorption of bone around that area with osteoclast. And initially there will be formation of woven bone, immature bone, and after a few weeks, these all woven bone will be replaced by mature bone, that is lamellar bone. So this healing process takes place around 3 to 4 months. So according to Brainemac, we should not load implant in this healing period. But nowadays, there are a lot of changes in implant surfaces, implant design, and there are protocol which we are following. And according to which we can load implant, but there are criteria. So the primary stability should be more than 35 Newton centimeter. Okay, and the crown which we are giving, it should be out of occlusion. It should not just it is for the aesthetic purpose only. So we cannot eat hard food with that. So there are protocols for that which we have to follow. Otherwise, there will be failure of implant. So next, after process of osseointegration, so what are the factors influencing osseointegration? First one is material. So material, we should use commercially pure titanium. Why? Because it is the best demonstrated material to achieve osseointegration. So if we use other materials, we may not achieve osseointegration. So first one is commercially pure titanium is the material to achieve osseointegration. Second, design of the fixture. So I told you screw shape design is nowadays most commonly used. So why it is most commonly used? A screw shape gives surface enlargement. So if you know in screw we have threads. So we are giving threads on that screw which will enlarge the surface area of implant. So surface enlargement for interaction with recipient bone tissues. It helps balance the force distribution into the surrounding bone, enhances initial stability, that is primary stability, and provides resistance to shear forces. So design of the fixture is again very important factor which influence the osseointegration. First, second, you can write down third. Bone should not be heated beyond 43 degrees centigrade to maintain its vitality. While drilling alveolar bone, we are using drills, right? So it can heat, it can produce heat while drilling the alveolar bone. And that heat should not be more than 43 degrees centigrade. So to follow this factor, we use coolant, we use normal saline irrigation. So nowadays we have the device, we can directly attach the irrigation tube in the handpiece, and that area where we are preparing bone with the drills, so there will be continuous irrigation so that the temperature can be maintained. So when the temperature exceeds, alkaline phosphatase begins to break down, which may cause failure of implant, which can cause failure of osseointegration. And ideally, it should not exceed 39 degrees centigrade. Normal procedures requires fixture left undisturbed for 6 months in maxilla. So initially they say that if you are placing implant in maxilla, you have to wait for 6 months. And if you are placing in mandible, then 3 months. So what could be the reason? 3 months in mandible, 6 months in maxilla. The reason is mandibular bone is dense. If you compare with maxilla is a soft bone. Why? You know why maxilla is soft bone? So mandible is a movable bone. Okay, mandible can move through the temporomandibular joint. So, and maxilla is a fixed bone. So while chewing, the force from the mandible will go into the maxilla. So we need maxilla to resolve that force, to absorb that force. So that's why that maxilla is a soft bone to absorb the masticatory force. So soft bone healing will be delayed. Dense bone, mandible, healing will be faster. And again, according to Brennemark, no loading while healing is the basic tenet for successful osseointegration. And if you want to be sure for osseointegration, it's ideally not to give ground, not to give load on the implant till these periods. Next, surface properties. The property of implant, that means the desired surface properties should not be changed by microbiological or metallic contamination during any part of manufacturing, storing, transporting, sterilization, and surgery. So this means that the implant surface should not be contaminated by any way till you place implant in the patient's mouth. So that's why while placing implant, you should not touch the implant with any instrument, anything. And if implant falls down, then you have to change the implant because there will be changes in the property of implant surface, which can prevent osseointegration. So you have to place sterile. The implant comes in implant box which is sterilized, and you have to place that implant without touching anything in the alveolar bone. Fixer side positions. So the most important principle is to achieve good initial stability and the full coverage of fixture, that is implant, in well vascularized, highly osteogenic bone. This is again important. You have to place your implant within the bone. It should not be exposed outside the bone with good initial stability. And the bone should be well vascularized. A vascular bone, like in case of uh, we have discussed about contraindications like radiation therapy. Radiation therapy can cause the blood vessels around the bone, so it will make after your radiation therapy, vascularity will be decreased due to radiation, and that can cause failure of implant. That's why we have to wait certain time after radiation therapy. Even your osteoporosis, in osteoporosis, again vascularity is decreased. So that's why, so we have to be very careful in those conditions where vascularity is not proper. Load bearing capacity. So load bearing means quality of implant, quality of bone, and the total interface surface of all fixers that determine the load bearing capacity. So load bearing capacity is slightly smaller in maxilla than in mandible due to the capacity, due to the nature of bone. So success rate is usually higher in mandible than in maxilla. Okay, Azukla, I think